Hi everyone, welcome to ResearchHunter.com. Another great presentation today. Today we're going to teach you everything about choledocholithiasis. Okay, so somebody tell me what's the definition of choledocholithiasis?
It's gallstones in the common bile duct.
Gallstones in the common bile duct. Okay, very good. Okay, so gallstones in the common bile duct. We made a great presentation before about cholelithiasis. So it's kind of like please go back and review that. So when you talk about what are the causes? It's more common in females, usually age greater than 40 years, okay? And then etiology, again, because of where does the stone comes from? Stone can usually come from gallbladder, but the stone can also come from where?
Due to secondary causes, it can be due to biliary stasis.
Yeah, it can be biliary. Wherever biliary stasis, the stone can form. So always don't imagine it's all the stones is coming from gallbladder. Okay, remember that. So if he has bile stasis in the common bile duct itself, he can have stone. Right? Yes. Everybody got that? Okay, and then clinical features, usually people have right upper quadrant pain, usually greater than 6 hours, epigastric pain always ready to wear, right shoulder, right? Remember that. And then nausea, vomiting, anorexia, they can, you can have jaundice, dark urine, and pale stools. Why do we have dark urine and pale stools? What's the reason?
Because there is no...
because of the bilirubin, right? Bilirubin's kind of high. Usually, can they have itching?
Yes, they can have itching as well.
But it's it's less compared to let's say the malignancy, more itching is going to say. Let's say there's a malignancy and there's a blockage of common bile ducts. Studies have shown more people complained of itching, but in this it's less when they did the study. Remember that, okay? So now let's look at our pathophysiology. It's very important to know where the stones, what type of stones. What are the most common type of stones?
Cholesterol
stone, around 65 to 70%, right? Just so when we look at it, you have increased cholesterol. Where do we increase cholesterol? Usually metabolic syndrome or liver produces cholesterol. There's more cholesterol, okay? Usually you got phospholipid and bile salts and they become soluble biliary cholesterol and get reabsorbed in the system, okay? That's a normal mechanism. In the abnormal mechanism, what you get is you're going to be decreased phospholipid, there is decreased bile salt, increased cholesterol, remember. Number one, this is increased cholesterol. And then usually this unilamellar, when you have in abnormal situation, they become multilamellar, okay? And then there's a nucleation process going on. And then that kind of monohydrate, you got cholesterol crystals and microliths, and that is the cholesterol stone formation, Justin. Also, you have, when you look at it, there's mucin and calcium helping the nucleation process. So remember the nucleation. Everybody got that, right? And then when you talk about, when you have in the normal situation, you got apolipoprotein and lecithin IgA inhibit the nucleation process. Okay, that is in the normal situation. In this patient, it doesn't happen when you have cholesterol stones. Now, the other two types of stones, what are they? Somebody tell me the name.
The pigmented ones, black and brown.
Let's start with the black stone, right? Remember what they are what type of situation? Black stone, is it a sterile situation or infected bile?
Sterile.
Very good. Always remember that, okay? In black stone, it's sterile situation, and in brown, it's always infection. Right? All right, let's go to black. There's chronic hemolysis. Usually if I'm writing a question, I talk about patients who have sickle cell disease and all that. Sickle cell crisis pretty much. Unconjugated bilirubin. And with the calcium, you can have calcium carbonate stones, calcium phosphate stones. Okay? Everybody got that. So, and then you have brown stones. Brown stone, you have to always the infected bile. There's an infection going on, right? Everybody got that? So you have functional status bile duct, you got conjugated, and then unconjugated bilirubin with the calcium, you got calcium bilirubinate stone. Remember that. The best way to remember is this is black is you have sterile bile, right? And the other one is infected bile right here at the top, okay? So these are the three main types you usually have. Then I think it's important what happens once you have the stone, they have to move out of there, right? That's where choledocholithiasis, right? So it's good to know the anatomy a little bit. So you got gallbladder, then you have cystic duct, then you got the common hepatic duct, they combined into the common bile duct, right? And then you got the pancreatic duct comes in. right? So you got the stone kind of moving over here. Like, I mean, the mistake people usually think, and they always only think gallbladder is the only one where the stone is, right? Let's say, let me ask you this. If a patient go and you take the gallbladder out, can they still have the stone?
Yes.
Yes.
Right?
Yes.
We already said, you know,
Yes.
anywhere bile stasis, they can have stone. Let's say if I'm removing the gallbladder out, they can still have the stone at the stump. So don't make
Yes.
that mistake. They can have the stone over here also. Okay, the next thing you need to know, once you know like the size of the common bile duct, right? If you cannot express in numbers, that means you don't know the situation. So one number you have to know. Somebody tell me what's a normal size. Don't say like from 0 to 10 or 10 to 20. One number, what is that?
6.
6 millimeter, okay, that is the number. If it is like that, I should etch that in my mind. And anytime I see like I'm looking for gallbladder, I need to know. If you don't know anything about anything else, remember common bile duct, the normal size of the common bile duct. Okay, so 6 millimeters. So what happens is like when you have a stone, what's going to happen? It'll get dilated, right? There's an obstruction right there. So, I mean, we'll come back to that. So, can the pancreatic duct also become obstructed, right? When what happens when you have a stone right there? If you block, you can have pancreatic. Like, what do they get?
Pancreatitis.
Pancreatitis. What is it called?
Biliary
Biliary
pancreatitis.
pancreatitis.
A gallstone pancreatitis, probably, right? Because the stone kind of. Did anybody? I mean, everybody understood this, right? Then it's like two situations when somebody. We also need to know what happened to the older people. Let's say your grandmother who's 80-year-old, you did an ultrasound, you found the common bile duct is like 8 millimeter, or you say like 9 millimeter. Should we be worried?
No,
Why is that?
because as we age, the bile duct diameter increases as well.
They already have wrong. Okay, that means like there's something called senile dilatation of the common bile duct. Remember that. When like if your grandmother, 90-year-old, get an ultrasound, and then all of a sudden the report came back, common bile duct, you get a call. Don't worry, that's something called senile dilatation. Okay. Let's say you did another situation, right? The common bile duct come back like 12, 14, and I'm still not worried. What's that situation? What is it called? Cholecystectomy. Okay, let's see, this is what happened, right? You take a gallbladder out. What is the normal physiological process is like this thing is going to get expanded. There's a dilatation already. Remember that, don't panic. So first thing I do, like, I get a report saying common bile duct, like an ultrasound or something, common bile duct is like 12 centimeter, right? The first thing I always ask is like, is it a senile dilatation? So I look at the age, right? Usually 8 to 9. If it is 12, I know it. There cannot be senile dilatation. Next thing I would ask is there like, did the patient still have the gallbladder or they have taken the gallbladder out? Remember that. Okay, because once you have taken the gallbladder, there's something called a physiological dilatation. The common bile can dilate up to what? 12 to 14 millimeter.
Yes.
Remember that, okay? So it's very important to know those situations right here. Did everybody understood this? If you don't understand, and that's the most important. What is the number again? Somebody said? What is the common bile duct?
6.
6 millimeter. What is the size of the common bile duct again?
6.
6 millimeter,
Yeah, 6
right?
millimeters.
So what is senile dilatation? Somebody tell me, what is senile dilatation of the common bile duct?
It's
More than 6.
More
Yeah,
than eight.
let's say around 8,
8.
like older people, that's like common, okay? So what happened in post-cholecystectomy? It get dilated, right? There's a normal physiological dilatation could be 12. So if somebody always asks the patient to have cholecystectomy done and all that. The last question, can you still have gallstones after cholecystectomy?
Yes.
Okay, yeah, a lot of people make the mistake. So you did all that, now we understood all the situation. How do you like the lab? What kind of lab you should check on? Somebody. Alkaline phosphatase,
Yes.
right? Do we fractionate it? Right? You have to
Yes.
know like where it's coming from, right? What are the 3 places we say like, alkaline
bone,
phosphate?
placenta.
Huh?
liver,
Please.
bone, and placenta.
Liver?
Bone.
Bone and placenta, 3 places, okay? So we know that. That's why we do alkaline phosphatase. You always fractionate a GGT, right? Then you have the bilirubin. Usually these people like bilirubin. Why? Because that's a blockage, right? So if it is, we'll come back to like why is it important and all that. So let's say what is the imaging study you do? Ultrasound. Is it a direct measurement of the common bile, the stone? Can it measure if there's a stone or not?
No.
No, it's an indirect measurement. It's just looking at the shadow and find out it's dilated, okay? They can never tell you if there's stone or not. It's an indirect measurement, okay? And so it's a pretty good test to look at it, right? And then what is that? Let's say if it's dilated, what's your step? You do a ERCP or MRCP? What would you do?
ERCP.
What decision? How do you make the decision on the ERCP? Or like get an MRCP? MRCP, like, sensitivity is around pretty good, 95, right? What is the difference? Who make the decision?
Because it's a diagnostic and therapeutic as well.
Yeah, that is a good point. Okay, let's say let's say the bilirubin came back greater than 4 and your suspicion is high, always go for ERCP,
Okay.
right? Because otherwise you have to do MRCP and then come to ERCP. If the suspicion is a little bit low, I would go with MRCP. Very expensive test, but good sensitivity and specificity, probably around like 95, 98 kind of range, very high, right? And then you can do an ultrasound, in invasive ultrasound, you get sensitivity also, and that's the other way. Later stages if you want to. Treatment, again, we talk about ERCP, laparoscopy, bile duct exploration. If you cannot do all of that, there may be a little bit wrong with the lithotripsy. Okay, remember, always like ERCP, you take the stone off, and then sometimes if there is like a stricture, you have to do like a sphincterotomy right here. Okay, remember that. That's a role for that. So, the other thing, you need to, when somebody do when you do ERCP, right, always make sure the INR is normal because a high risk of bleeding. Okay, so before, if you have a common bile duct stone, okay, you're a patient, you consult in GI, they're going to do an ERCP, and most likely they have to do sphincterotomy. The risk of bleeding is extremely high. Okay, so remember that. So always check an INR because that is like a very high risk for bleeding. And then symptomatic treatment, the pain control, spasmodic and antiemetic you have to treat. And when you talk about the complications, there's cholangitis, cholecystitis, acute pancreatitis. We already said the gallstone pancreatitis. And what's our differential structure? You have to rule out the biliary stricture, pancreatic cancer, and cholangiocarcinoma. But in a nutshell, we need to know what is choledocholithiasis, right? That's like stones in the common bile duct. We know what? Females, right? And then we talk about the symptoms and all that, pain radiating, talk about the jaundice and all those kind of thing, okay? Because of the high bilirubin level, then it's good to know, once you know the pathophysiology, how the cholesterol stone forms, right? 2 types of stone, black and brown. Remember, brown is infected, this is sterile stone. And then you come up here, you know the structure. You need to know everything about it, right? You know where the cystic duct come in. You got the common bile duct come in. It comes CBD. And remember then, one more time, I'm going to ask what's the size of the common bile duct, my friends? 6 millimeter, okay? And then you got this pancreatic duct, they can pancreatitis, we talk about role of lab, alkaline phosphatase, always fractionated, check for bilirubin level, and you direct and indirect, you have to check an ultrasound, ERCP, and look at the complications if you don't treat. Okay, thank you so much for watching. We'll be back with another presentation. Please subscribe to our channel. Thank you.